It was about helping others think differently. It was about helping others see what their role was in a process. It was about helping others see what the roles of other people were in a process. We all get frustrated with colleagues at times thinking, oh, why can't they just do X, Y, and Z? But actually, that's probably because they've got their own remit they need to stick to. They've got their own bits they need to stick to. And we've all got those silos in working, and to bring ourselves out of those silos, or at least understand each other's silos, it just helps the process so we can actually help each other improve things. Like I say, co-production I mentioned earlier is absolutely key. I think it's great that we've got a huge toolbox of all of these QI tools, but I think the most important thing is to work together, and that engagement and that ability to speak to each other is probably the most important tool for me. So I did some secondment work with the improvement team of my trust at the time. We've got across various projects, everything from HR processes to logistics projects to supply chain to clinical efficiencies and patient flows. At that point, I moved trusts to my second trust I can't exactly remember what year that was, and joined a change team there. That was going relatively well until a change of leadership at the very top level brought in what was quite a vast frustration for me, was that quality improvement program turned into a cost improvement program. Now, for those of you involved in service improvement, you may agree that if you're looking for cost improvement rather than service improvement, it tends to go in a downward spiral, because if you cut costs, the quality seems to follow it out the window. My own personal opinion is if you get the improvement of quality right and the balance of everything right, I think that the money falls into line itself. So that's what led me to leave that trust after a few years and join Trust Innovation Group, where I find myself now, which is about 4.5, 5 years ago now. We get all kinds of internal and external work. Just to give you an overview of the team, we do our own in-house project management training, we do quality improvement training, and we quite often get asked to speak at events such as this. We do a lot of external work, including some international programs we have ongoing. I think currently the only one we have ongoing is India and Singapore, I think, which is one program, but the rest of our work is currently internal. Now, until COVID, we did work in all 4 corners of the country doing various events, of which I'll talk through our process in the coming slides. But the Trust Innovation Way really encapsulates service improvement, and it puts it as our main aim, not just project management, not just to hold a document, but to help others think differently and to see the whole process. So some of the types of work we've done. My screen's just taking a second to catch up, sorry. So just some examples of the kind of things we've done. We've done surgical improvement. Certainly my background is included in that. We work with new clinical systems to try and implement them. We obviously know that clinicians, these systems come in and they're not always exactly how they want them. I think some trusts still have a bit of a tradition where the IT department pick the system that's going to be used, when actually the clinicians are the ones who know the remit and know what's needed, but they seem to be the last ones who get liaised with as to what is it you actually need this system to do. We've worked on projects and programs around improvement to patient user apps, how to access services, creation of call centres for mental health trusts so that service users can actually get in touch quicker and reduce things like A&E admissions, reduce the need for crisis, and do sort of that step up, step down function. We've worked on provider collaboratives, where it's obviously becoming a bit more of a priority of NHS nationally for trusts to work together across the boundaries to provide better services. We've done emergency service co-working. We've redesigned children's services. We've looked at patient flow systems, and more recently we've been responsible for setting up our own trust's COVID absence system and the testing program that came with it. And you say there's a whole list of things on there, including training and many more that it simply slipped my mind as my years roll by. So why is a project different to service improvement? And again, this is all down to opinion. Some of you may be absolutely rigid in your Prince 2 ways and stick to that and find that works for you. And if it does, absolutely fantastic. But for myself, I find a project, you get given this set remit of, we are currently at point A, we want to be at point B. It has very set goals and guidelines. The project management of that involves that holding of document, organising the meetings and sort of documenting what gets done and sort of ticking that box when we get there. To me, service improvement is a case of, we know it's not working through one of the ways I'll show you in a couple of slides. We need to improve on that for the patient. You've just put that patient value slide up earlier, which is, I think it's a great picture that paints that one. Service improvement, it has no set boundaries. We don't know where we're going to start. We don't know where we're going to end. It's all part of the baselining to see where the work needs doing, not necessarily we're going to do this and see if it helps. So at the onset of an area, a trust, a service that needs improving, remembering this could be as small as working with an individual team, it could be as large as working with multiple trusts, it could be a whole system transformation, or it could literally be changing the way a letter is sent to a patient. But we have a triangulation of information sources. Again, from your previous slides, we love a triangulation in service improvement. We seek feedback from all parties involved in a service, be that from service users. That could be complaints, it could be compliments, it could be serious incidents that crop up. We look for feedback from carers, we look for feedback from the staff surveys. We also look at things like CQC reports of whatever it is we're looking at, if it's a trust, if it's a service, if it's a team, whatever, and that starts to paint that contextual picture. We also, and this isn't always my bag, I'm not a numbers person, but we look at data as well. We have a couple of data analysts within Trust Innovation, which are a huge resource for us. But we look at performance data, we look at patient flow, discharges, admissions, length of stays, how long are people within other services, community services, crisis services, how often are the same people bouncing in and out of services, and so on and so on. We look at actual outcomes. We look at are we able to help this person? Do they have to go sort of externally to the footprint of the service we're looking at and seek help elsewhere? And we also look at staffing. So how much of the staffing complement is fulfilled? How many vacancies do we still have? What is sickness like? And so on and so on, even down to the structure of the team, how many bands there is, what roles they play, and so on and so on. That's the cold, hard data. Again, each one of these things on its own won't paint that contextual picture. It simply it adds to that triangulation. You need all of these features to really paint a picture of what's going on, so you can start digging down into where these improvements could be made, or start doing your 5 whys, or drilling down into where the problems lie. And we also carry out an observation of teams, of clinical teams, of admin teams, of any team involved within a service, within a trust, depending on what it is we're looking at. We do documentation audits, obviously with trust and service permission. We do a cross section of patient case notes, for example. We look at how sort of thoroughly they're filled out. Is there anything missed? Is there anything that should have been filled in? Are we filling in too much? Are we duplicating? We look at even down to staff movement. We'll go to wards and clinics and workplaces and offices and look at staff movement and see where the waste is. Our processes taking all day that should just take an hour, and so on. We look at timings. We'll pick up on individual processes within a department, within a team, and we'll literally do timings of how long it takes and ask questions like, why does it take that long? Why is there a gap in the middle of the timings? And we've all encountered a change project where it comes down to something like this process used to take a day, but now it takes 5 days. And the reason being is because Gladys, who's pivotal to it in the middle, has gone semi-retired. She only does 2 days a week now, so the process stops for 3 days until Gladys does one of her 2 days a week, and then it continues. It's funny what you can pick up in little things like this, but again, it's when you work in your own silo, you don't recognize it sat at your own desk. We even look at things like interruptions. What stops you from getting on with your business as usual is an understaffing thing, so you constantly get drawn away to do medication rounds or answer a telephone that's not manned or anything in between. What are those interruptions that stop you from getting on with your day-to-day basics? And we look at the wastes. I think the waste wheel might have been pictured on one of those previous slides. We like people to try and understand what a waste is. It's okay for us putting a slide up saying, oh, we're trying to reduce waste. Now, some people may take that as we need to recycle our paper in the workplace. At the other end of the scale, some people might say, I spend all my time doing X, Y, and Z, and that's not my job. But by understanding what these wastes are, again, there's where another tool comes in, that waste wheel. It means we can work with people. So all that feedback, the observations and the data combined give us a really clear picture of how a service is working, and allows us to feedback to everybody within that service and say, this is how you're currently working. So we need to now drill down and do a little bit more about it. How do we do that? So as mentioned, we always like to go for a co-produced redesign. I'm hoping, in most trusts anyway, gone are the days where the chief exec says, things aren't working, I've decided this is what we're going to do. Because with the best will in the world, the chief exec does not know what is going to fix it. The senior managers do not know what's going to fix it. Certainly myself, and I know Matthew, who's on the call as well, I think the first person we head to when we go and work with a new service and understand what's going on is the person that greets us at the door, whether their title be secretary, PA, admin, whatever. They're the first starting point of the most important people, because they know everything that's going on. They've probably got a better handle of everything that's going on than most team managers. I think we all know an admin who could literally run a department on their own. So we head in and speak to the frontline troops, the admins, the frontline clinicians, those who are working at the coalface and understand what the problem is. And we've got a few principles we work to when we involve different groups. When it comes to change, we don't just like people who are involved in the immediate service. We like those who they will hand a patient on to, whether that's the third sector in terms of mental health. It might be the ambulance service in the acute. It could be the police if there's police involvement, the local authority, the GP, the primary care sector. All of these parties who are involved in a process need to be part of the co-produced redesign, or at least encouraged to be part of it. We can't press gang people, but an invite and an informative, this is what's going on, always helps. So we involve all parties and we do a summary of why and how the projects come about. Some people might be in that broken silo, that complete tunnel vision of, well, I know it doesn't work great, but this is how what I've done for 20 years and I don't want to change. So they kind of need that. This is why we're looking at it, because it isn't serving people as well as it should, or we need to serve people better, or times have changed, and so on and so on. What we make sure throughout is that anybody's happy to come to us. There's no silly questions. Every voice counts. Every opinion, every experience, every thought, every opinion is absolutely valid from the point of view it's coming from, and therefore it's valid to the bigger picture. Any managers involved in change projects and service improvement projects, we ask that they have big eyes, big ears, little mouth. We want them to take in all this information. We want to take in the opinions, but we don't necessarily want them coming up with the, well, no, that's not right. I'm sorry, if there's members of your staff, members of the wider co-produced group are saying that is the case, then there's an element of it somewhere and we need to take it into account that something's not quite right. We encourage blue sky thinking. We don't want to say, well, this is the service as it is now, it doesn't quite work as efficiently as we like, but let's just tweak it a little bit. Well, no, because all we're going to get is the same broken service with a few tweaks. It's going to have a different coloured font on. That's all it's going to have. We encourage people to think differently. We encourage people to think transformationally. Again, I think I've put it in a slide coming up, but we tell people, aim for the stars. And if you want to get as far as the moon, you're a heck of a lot higher than where you started. Don't just look to make little adjustments. Look to be as bold as you can. And think simple but bold. There's no trick questions. Anything we ask is simply trying to help people to think differently, to think of where others are coming from within the same process. We always facilitate with a view to encourage debate and play devil's advocate, but never influence. Ask a question to help people, to make them think differently, to consider things from the other side of the fence, but without actually saying to them, no, this is what you should be doing, because then that's not co-production. That just goes back to the chief exec saying, this is what we're going to do. And throughout, make useful resource available. There's lots going on across the country in terms of improvement, both at a national level, a local level, and so on and so on. I think if other people have done improvement projects or have things going on, put your hand up, ask them what they're doing. There's no harm in finding out what somebody else is doing. There's no plagiarism when it comes to serving patients in the best way. So our principles around quality improvement and lean methodologies. Basically, whatever we're doing, you've already outlined this, is the end product, the outcome of it must be an improvement for patients, service users and carers. That's the absolute crux of everything we do as a service. And I think sometimes that gets forgotten a little bit. Again, in terms of the blue sky thing, and try not to cling on to the past, but how good could we make the future? How different could we make the future? Just because we've done something in a certain way for the last 80 years doesn't mean we've got to keep doing it the same way for the next 80 years. Technology allows us to do things very differently. If we can embrace it, let's do it. New treatments, new therapies, new ways of working, new organisations who support the NHS are all out there. Let's actually utilise them and get the best possible outcomes for service users and patients. The more variation in anything, documents, processes, resource, work and practice, the more inefficiencies there is. If you have 10 teams and they're doing things 10 different ways, there's 10 different ways things could go wrong. I think where possible, create a consistency. I know particularly in CNTW, we have quite a large footprint from basically pretty much from Kendal upwards to Berwick on the Scottish borders all the way down to just south of Sunderland. It's a huge footprint. Now, consistency we try to obtain as much as we can. We have an 80-20 theory where we try to make 80% of everything the same right across the patch, but that 20% is always affected by the geography, the makeup of demographics. We've got quite heavily populated urban areas in Sunderland, Gateshead, Newcastle, but then we also have the northern half of the Lake District and the Northumberland Fells, which other than sheep and cows, there's nothing there. So obviously we that 20% has to counter for that. How do we work differently in a rural community? But again, the more consistency you can bring in, the better. We can't make large scale change alone. Again, be this the chief exec making a decision or somebody at the shop floor who's like, I'm going to do things differently. You can't do it because everybody else in their little bits of the process attached to you are still going to be working in the same old way. Whole scale transformation needs everybody to be on board, and it needs everybody's experiences and skills to make it a quality improving and effective change. And like I said earlier, if you aim for the stars and land on the moon, you've progressed. So change will happen in stages. Change is rarely big bang. The NHS is so complex and so diverse now that nobody can flick a switch overnight and say, right, we've changed how we do everything top to bottom. We do a lot of our work in what we call staircase plans. We will design blue sky, we will aim for the stars, but then the delivery plan, when we come to implement that, will be, right, how do we put our foot on the first step of that staircase with using what we have in the first instance in terms of resources, staff, estates, technology. Which bits of the plan can we implement first? And then we look at the next step and the next step. And that's like those stages that change happens in. Am I going too fast? I do talk quite fast. I apologize. Anybody got any questions thus far? I'm more than happy to answer them along. Please pop a hand up if anybody wants to stop me and ask. And if I do use any terminology, I try not to use too much terminology. I'm wary of the comment earlier that, I can't remember her name. She said that some of it had been a little bit above us. So I'm very keen to use layman's terms where possible. So then it comes to the implementation of, we've looked at where the problem areas are. We've looked to redesign with a co-produced group. We've looked at how we're going to deliver that. We're looking at how it's going to improve quality, and then it comes to that actual implementation. So this bit does rely on a little bit more traditional project management. It does need those steps of the staircase where we're going to do this, then this, then this. But there's still some principles we apply to that. Apply quick fixes where you can. If any quick fixes come up at any point during a quality improvement process, a transformation project, put them in. If they're a quick fix, then why wait? They're not quick if you wait. What that will do, it'll empower staff. It'll make them feel like the work that they've done thus far it's being listened to, it's being implemented, and that buy-in, that engagement you'll get from a much wider co-produced group will simply keep them involved. It'll keep them coming back. It'll spread the word that, things are working differently now. We've suggested these changes and they're starting to happen. That empowerment, that hearts and minds work is absolutely crucial in service improvement and transformation. But then to identify how things are changing, we need those dashboards. That's where the cold hard data comes in again as well. People may, we may get constant feedback from service users and carers and family, etc., saying, things are better, I've been seen quicker. But again, you need that cold hard data to back that up. So where possible, create dashboards. If you've got communications groups within a transformation project where, you've got all the different organizations, get the data out there, let them all see what's changing. And maybe somebody might spot something of, why isn't this bit changing? That's where, your PDSA comes in. You've got that focus area to look at to make that continuous improvement. And I was told this long ago, improvement only occurs if it can be evidenced, because you can build on it when it's evidenced. But if it's not evidenced, it just floats, and it will float away eventually. Reflect and feedback often. Again, look at how that feedback comes in, but join it up with the data. Does it support each other? Does the feedback say things are getting better, but the data suggests things are getting worse? Do we need to review any focus areas? Can new practice be shared? Again, keep going out there and see what other trusts are doing, what are other parts of the country doing. How could we apply that to ourselves? And again, we may need to alter it slightly, and tweak, tinker, and talk. Whatever you've done, just because you've set it in stone, we said that things have been done like that for 80 years. If we change something now, it doesn't mean our change has got to be in place for 80 years. Tweak, tinker, talk, keep the improvement going. If somebody's found a little improvement on what we agreed to do, well, let's implement it. Let's see how it goes. Let's test it. An improvement doesn't end. I think whenever we do any kind of improvement project, transformation project, what we need to embed in that is a way for the stakeholders within that, all of the organizations who are involved in that service, in that process, to own the service improvement ongoing. What we don't want is 10 years time to have to redo this whole transformation project because what we did 10 years ago is now out of date. What we want is for it to be kept updated as time passes. We want people to own it. We want people to be coming up with their own ideas. So we do QI training with people, with the stakeholders in a process as they go, and help them understand how to think differently, how to see everybody's point of view, and how to identify a potential change when it comes up, and how to implement that, who to go to, where to go to, how to make the suggestion, how to highlight, how to evidence the change, the improvement it could make. So again, that's something that should be built in throughout all of these steps. So today I've been asked if I could focus on one individual tool. and it's not too big a group, which is great. So we'll just do it as a conversation in the room. So when we start, we mentioned looking at where we start. So if a trust or a service or a team had come to ourselves in Trust Innovation and said, we've got this problem, we don't know what's causing it, how do we drill down onto it, we need to improve things, we need to bring ourselves up to date, whatever their trigger is for coming to us and say, we need some improvement work done, there's a few different ways we could do that. So if it's more of a trust-wide or a large-scale service, we'd maybe do things like listening events. We've actually done quite a few in North Cumbria over the years, where we didn't break the day into a section of the day for service users and carers and a section of the day for staff as well. And we'd have the same semi-structured approach where we'd bring them into a room onto tables and get them having the same discussions around the same areas, just to try and drill down over what are the problems, what's good, what's bad, what do we build upon, what do we need to do less of, what do we need to do more of. And again, it adds to that contextual picture. If I was working with a smaller group, just say an individual team or a department, rather than a listening event, it would do a SIPOC. Now, in some ways, a SIPOC it's a sort of a listening event. Different practitioners will do this in many different ways, I'm sure. As with many improvement tools, I find it best just to have it as a very informal chat. If that team has a team meeting or a regular slot where they all get together, even be it virtually nowadays with the power of Teams, then I request to go along and work with them for that slot. Now, during that slot, we will carry out the SIPOC, which I'll show you now. Has anybody, by the way, encountered a SIPOC yet? Has anybody, other than people who've worked with myself, perhaps? Or am I going to be speaking completely foreign to people here? Okay. Again, there's no terminology involved, so don't worry. So a SIPOC is basically, it's an acronym. It stands for supplier, input, process, output, and customer. I can send these slides on, and anybody who wants them can receive a copy if they want a little bit more information, or my email address is in the list. I'll happily talk to anybody through this or any other service improvement tool they would like a little bit more knowledge on. Assuming I have the knowledge, that's that's not a given. So what does a SIPOC actually do? Again, if I was working with a team, you got to remember me as the transformation practitioner, as the quality improvement project manager, whatever I'll be badged as on that piece of work. These are the things that a SIPOC would do for me. So anybody familiar with the process, if I went into a team and I don't know what that team do, I'm not clinical. I'll hold my hand up. I'm not clinical. That actually benefits me in many ways, because it means I can go in and ask questions. I can play a dumb. I can say, I don't know what you do. Talk me through it. And a SIPOC is one of those ways that can talk me through it. So it lets me understand what this team actually does, who does which bits, and why. Where does it feed into the bigger system? It allows all of the team to see the change process. Like I say, they've all got that tunnel vision. You could have a team of 20 people who've all got that little step in the process that they work on, but they actually don't know each other's steps. So the SIPOC gives them an overview, gives them a vision of that as well. It allows them to understand what each other does, and perhaps allow them to come up with ideas of how they change that as well, or how they make that more efficient. It allows improvement to be identified through process change. So if we lay out the team's processes, it says, well, we could do this differently, we could do that differently. It's a starting point. SIPOC is very much a starting point. Other tools stem from SIPOC, but this is for a small team or department level transformation or service improvement event. This must be a first step. And again, we mentioned quick hits. It allows quick hits, and as you'll see when we talk through the SIPOC process, it highlights quick hits straight away, so we can get the ball rolling on that. So how would we do a SIPOC? Again, there's different templates. If you Google SIPOC, it'll show you 3 or 4 different ways of doing it. Some people lay a SIPOC out as a full, almost like a process mapping event. I would err on the side of not doing that. I think it's an informal chat. It's an information gathering. It's a first point of what's going on. So again, there's the SIPOC table that I use. I use something that looks like this. Again, the headers across the top. Now, I know because we work in the NHS, supplier very much sounds like somebody we buy something from, not necessarily the case. Customer sounds like somebody we sell something to, not necessarily the case. SIPOC's traditional. It's been going for many decades now, and it's across all industries. The acronym wouldn't work if it was patient. SIPOP doesn't sound quite as good, does it? So the supplier is basically anybody who supplies. It could be something we buy. It could be somebody who physically sells us something that allows the process to happen, or it also could be somebody who puts physical input into the process to allow the process to happen, be that materials, time, anything. The inputs are, what are these materials, information and expertise that are put in that allow the process to happen? The process column is just that. And I've got an example in a moment, but if I went to work with an individual team, I want to know, what are the processes you do? If it's a ward, we do day cases, we do intravenous therapies, we do inpatient stay, we do OBS, we do whatever it is that clinic would do. That would be a list of their processes, the things they do, their main functions as a department. Outputs are, what are the outcomes created by this process? So you might be thinking that it might be the actual therapy, it might be the patient notes that come with that, it may be referrals, it may be anything. Again, I'm talking as if it's a clinical department. This could be any kind of department, any industry that you do a SIPOC for. And the customer who is served by this process. Again, the last column, because we work in the NHS, tends to be a little bit more linear, with less options in it than if you were working in, say, the motor trade or the telecoms trade in my background. Your customer tends to be your service users, your patients, your carers, and maybe other departments within the trust, maybe the ambulance service, maybe, you know, whatever your interlinks are. But the customer tends to have less boxes in there. Matthew, you want to come in there?
Just very quickly, I can't see any slides, Johnny, so I wasn't sure if, are you sharing a screen at the moment?
Oh, I am. Can people see
You
them?
are, sorry. It's obviously, I'm going to leave and rejoin and see if that works. No problem. I'll just
No
check
problem.
it. Thank you.
No problem. Must be a thing about my colleagues past and present with technology issues. I apologise. Okay, so I'll just give Matthew a second to dive back in. I think he's joined. So in modern times, I'll stick with something that's on all of our radars. So we'll just do a bit of a test template. So if I was going to work with a COVID testing centre, and I was going to do a SIPOC with them to see what's not quite going right, you know, how could we improve it? What tweaks do we need to take? I'd go along and say we have this informal chat with them. What we've identified, the great thing about a SIPOC is it doesn't matter which column you fill in. You can fill it in literally any order. It doesn't actually matter. So in this instance, I went to them. My preference is, as a quality improvement practitioner, is I like to understand the processes first to get in my mind, what is it that this team does? So we've populated this COVID testing team's processes. They do PCR swabbing. They send the swabs to the lab where they then get analysed. They are responsible for sending text and email results back to the people who've been tested, and they also have a booking system which is both manned and online, we'll say. So that's their main 4 processes. So what might the suppliers be in that instance? I'll open it up to the room a little bit, see if we can sort of get that understanding of what a supplier might be on a SIPOC. Anybody, what do we think a supplier could be towards any of these things?
The person providing the swabs. So there's going to be a lab providing the swabs.
Yeah, the swab kit supplier, absolutely. Yeah, so that is a physical supplier who does actually sell us something. I'm not quite sure how the procurement during COVID happens, but I'm presuming we pay something for it. So yeah, there's the swab kits themselves. Who else might be a supplier?
You'd have probably knowledge around who's eligible. So there's going to be somebody providing you with some data around people who are eligible to have the
Absolutely. So like a governance
swab.
and guidance. Yeah, absolutely. So like to somebody who, a team or a department somewhere, be it at local level, national level, who create a guidance, a criteria of who you should and shouldn't be swabbing. Absolutely. Any other ideas? Any other examples? I know it's awful once you've been sat listening for 30, 40 minutes to my monotone droning voice, and now we ask you all to switch microphones on and speak to me. I apologise. Any other suppliers? What can we think of?
There might be somebody delivering the swabs, like transporting them from the lab to the
exactly that. Yeah.
Used.
Yeah, be that a courier, be it internal transport, be it both. Maybe they get sent to a central destination and then we have to request them from the central destination to all our individual test sites. Absolutely. It's all of those kind of things are definitely suppliers. Any other ideas to pitch in before we move on to the input column?
I guess supplying staff, Johnny, from the organisation to actually facilitate.
Absolutely. Yeah, absolutely. Staffing as well. So then what would the inputs be? So some of those inputs are going to stem from those people we've just mentioned. So what are the actual inputs that are going into, and I'll just read what my wording was. Inputs are worded as, what are these materials or information that are needed to carry out the process? So we've got the suppliers, the people who provide us with this information and materials, but what actually are the information and materials that we get the expertise, what are they? What's some of our inputs?
Well, the swabs.
The swabs themselves, yeah, the physical swabs, yeah. We've got somebody who supplies them, but that's a physical input, and I'll show you why in the next couple of slides, why it's important to really drill down on even the minutiae of what it is we need to do that process. So the swabs. What else have we got?
The
Well, you
vaccine
might s-
itself.
Sorry, I got a couple of voices together there.
The vaccine itself.
The vaccine itself, absolutely, yeah, not much good without that. So we'll presume they're doing vaccine as well, because our testing centre is the vaccine centre as well. Yeah, it could be anything that we're either swabbing or putting into our subjects, we'll call them.
So you're going to need somewhere to store them, whether that's fridge or cupboards or something. Anyway, yeah, whatever it requires to store it
So
appropriately.
again, link to the governance and guidance. It tells you you've got to keep these materials, keep them at a set temperature, keep them for so long, use them by a set date. Again, they're your inputs. They're the actual items that those guidance and governance look after. Yeah. What about outputs? What are our outputs?
Can I just ask a question about the inputs?
Yes.
I'm a bit slow keeping up. Would the input be the flow of the customer as well? Is that an input? Because it's the way
It
with
is.
which you're,
Yeah, it is. If you word it differently, so one of the, perhaps a supplier could be a software supplier who gives you a booking system, and the input to that is the patient flow. Absolutely, the patient flow, because somebody might still have to man that. There might still be a phone line looking after that booking system as well, so people can ring in for the older generation who haven't got online access. So yeah, you're right. The patient flow is still an input as well. Absolutely. What about outputs? What do we think our outputs could be in this instance?
Data.
Absolutely, test data. Yeah, I think the government at every step of this, or the WHO or the NHS England, whoever is getting the data, absolutely the one know everything, don't they? I think for those of us who had COVID, we've answered all the questionnaires, and I'm sure that the COVID test centres get 10 times that amount as well. Who's been in? How often have they been in? What was their result? And so on and so on. Yeah, absolutely. Any other outputs? I've filled an example table in, so it doesn't matter if we can't think of any more. I know people are sometimes not always keen to speak. I need a tumbleweed gif when people don't speak, just to kind of urge people just rolls across the screen until somebody switches their microphone off. What about customers? Who's the actual customers of a COVID testing centre?
The person being tested.
Person being tested, the general public, absolutely, and perhaps based on the answer we got there before, the health authorities, NHS England, whoever it is that wants that data as well. So is that making sense to people so far?
Yeah.
Anybody not? Anybody brave enough to put their hand up and say, I don't get what you're on about, Johnny, you're talking absolute gibberish? Or are we all happy enough with that so far?
I think, Johnny, I was just thinking, because if it was me that was facilitating this or whatever, I can imagine that, because this is, at the end of the day, this is just a mechanism to get the information and have a conversation. So in a way, it doesn't, or tell me if I'm right or wrong, it almost doesn't matter what column you put it in. It's not about getting bogged down, I suppose, with...
You're exactly right.
All the definition of the column, is it? It's just, it's having that conversation to make sure you've got all of the data to start with.
Yeah. If we were doing this, and I'll just pop the next slide on, if we were doing this with an actual COVID testing team, they'd all be pitching in. They would all have an understanding of the process. So rather than us trying to second guess what they actually do, they would have, an exact knowledge of that. And they'll be saying, well, we do this, this, and this. But then at the other end, they might be going, oh, I didn't know you do that, because I do that as well. And, but what we'd come up with was a table like this, where you're right. Some of them might overlap columns. You're absolutely right. But what it does, it gives us all of the things involved in one table with that team's processes. So there, I've put outputs down as the PCR samples themselves, the guidance to positive test subjects, which again, that could actually be an input. You're right, that guidance we put in the input, but it could be an output. But all it is to facilitate that conversation, to allow you as a change facilitator to go in, and suddenly you've got a better understanding of what it is this team does and what's involved. You haven't got an in-depth, because there's more tools would follow on from this, like process mapping and so on. But what this then allows you to do is start playing a little bit of devil's advocate with this team, and start going through box by box and saying, does that work? Does this work? Is this always okay? And what you start to get, you put your little markers against your SIPOC table, and they say, well, yeah, we've got staffing, but, they then have to be trained. So then, if somebody leaves, goes to a different trust, or stops doing the testing program, we've got to wait a week till we get trained staff, so we can't get through as many tests. There's the PPE supplier. Well, there's always delays in the PPE, so we're always having to make do and mend and pinch and borrow and all the rest of it. And then when the PPE gets here, the government did a dodgy contract with Turkey, so it's not even good enough quality for us to use. All of those things, we've probably heard some of these in real life through COVID. I know I certainly have. The samples not being picked up in time. My local test centre had an issue with that. The samples weren't picked up on time, therefore the analysis was outside of the analysis window, so they had to recall people as quick as they could to get retested. These are the kind of things where you get people to talk about the process, understand their own process, but then talk through each element of it and say, what could be better? What doesn't work? What does work and we need to build upon? What doesn't work so well and we need to make some changes to? And it's much easier if I went and had that same informal chat with a team and just sat them down and said, right, is everything working okay? They just go, well, yeah, I think so, yeah. Whereas breaking it down into a visual where you say, this is your processes, this is what you actually do, is it all okay? And suddenly you've got some quick hits there. Well, we'll change our PPE supplier, so somebody who'll get it here on time, it's better issues, better quality. We'll put in a trust-wide staffing initiative where we train X amount of staff to be able to swab. So regardless if they end up working in the test centre or not, if we call upon them last minute, they can step straight in and we can still maintain the same level of tests. The samples not being picked up in time, right? Instead of using a courier, we'll employ a porter and hire a van whose job it will solely be just to get those swabs to the lab on time, and we never ever have to recall people to the testing centre to have to be re-swabbed. And all of those things you can pick up. And where I've put a box in there saying the process, this bit here, it highlights different processes for more in-depth mapping, which, it's okay. And that's not a process map. That's just we book tests. We send an email out. Now, I've actually been involved in the absence line for most of COVID, and we have to hold a manual of how everything works. We have to assume that a member of staff could come in off the street, read this manual and know how to do the job. So that's where, if I went to work with the COVID testing centre, I would say, right, I need to make a process manual for how they send the emailed results out to people. People need to know how to use those systems. We need to know how the PCR swab's done, what's the training around that. We need to know how to use the book and test system and how to set that up so people can book in. And then it would allow you to then make more detailed process maps on every bit of the process that this team does, if that makes sense to people. Any shaking of heads? Anybody lost? Anybody thinking, what are you talking about, Johnny? Are we okay so far?
I was just thinking, Johnny, it would allow for you to decide which part of the process you map first, or maybe only map, because I think that's where, I know for us, when people get used to process maps, they think, oh, come and do a process map, and the start and the end are about 1 million miles apart.
Well, they are, and especially with something like COVID, where there's so many connotations now, you could end up with a process map that is so huge, it's never ending. Whereas, you're right, if you just highlight, well, this bit doesn't work, so let's take that bit of the process and fix those steps. Let's map them out currently and say what we change. Instantly, you've made a service improvement, and you've had within your own process, you've reduced the waste of not having to process map everything. You've focused on a focus area and you've blitzed it. It's a quick hit. Simple quick hit. Sorry, somebody's got their hand up and I can't see a name.
It's Melanie.
Fire away, Melanie.
You just asked how we're doing as regards understanding. I'm finding you brilliant, but I'm getting an awful lot of information. So if the slides can be and the recordings sent round, I can decompose your information because you've given us a lot. Thank you very much.
No problem. And like I say, my email address will be in the group. If you want to give me a follow-up call and talk through any specifics, then that's absolutely fine. I'm happy to help. No problem. And that offer goes out to the whole group. So let's see what my next slides are. Is there any more? So, and I do talk fast. Apologies. I think I was supposed to be on for an hour, but I think it's a northeast thing that we do speak probably far too fast. So I may not fulfill my whole hour, so I'll apologise for that. So the slide I'm putting in place there is basically what's next. So what we've just discussed there is it might throw up some quick hits. It might throw up some problems that we're not quite sure how to get to the bottom of. So this is where that wider toolkit comes in. Like I said, SIPOC is very much a first stop. SIPOC probably wouldn't be much good for a full trust-wide transformation program, but again, for an individual team or department, it would be my first stop shop. It's a way to go in and have an informal chat. It's a good way of introducing yourself. I'm Johnny. I'll be working with you to try and help you understand where you can fix your own service. I'm not there to fix it. I'm there to help you think differently, to play devil's advocate and to throw some different ways of thinking at you. We talk through it. We give them some quick hits. They start empowering those. And these tools are what we can. These are some of the tools that we can then build upon after that. So if it's, we could do waste walks. I think everybody probably familiar with waste walks. If it's a case of, some of the things that are thrown up is because the department's just so badly organised. Let's 5S them. Let's do waste walks. Let's do the spaghetti diagrams. Let's understand how things could be done quicker, more efficiently. We've probably all been on some kind of change work where 2 receptionists share a printer, but the printer sits on one of them's desk. So one of them does about 50 miles a year back and forwards, getting one piece of paper at a time, which holds each patient up by 3 minutes and adds an hour delay onto that one clinic each time. A random example, I know. But that's one of the tools we could follow up with. We could follow up with process mapping again. I'm very fond of process mapping and understanding where the process lies. But again, with SIPOC, as you mentioned, Karen, it saves you having to do the whole lot. You just focus on the areas that need some attention. There's the fishbone diagram, the 5 whys, all that kind of thing. Let's drill it down to what's the root cause analysis. We know we've got a problem, but why? And why? And why? And why? And find out the problem. And that top one there is just for those of you who are more logical sided of the brain rather than creative side of the brain, such as myself. That is exactly the same as a fishbone diagram, just done in a very different way. So that was SIPOC in a nutshell. I know it's difficult when I keep referring to the process, the service, but again, I try to keep it as generic as I can. I don't want to go down a clinical, an acute project or example, because some of us may be mental health on here. I don't want to use a mental health example for the opposite reason.
Thank you ever so much, Johnny. That was fantastic. It's great to have another tool in the toolbox.